All right, good morning, everyone. Welcome to day 2 of the ICEC Young Investigators Conference. I'm happy to see many familiar faces from yesterday, as well as new individuals joining us today. In keeping with the conference's title, Pioneering Action for Global Cancer Care, it's my pleasure to introduce Dr. Lowy, a modern-day pioneer in the efforts to eradicate cancer worldwide. Dr. Lowy is the Deputy Director of the National Cancer Institute and the Chief of the Laboratory of Cellular Oncology in the Center for Cancer Research. He graduated from Amherst College, then matriculated at New York University School of Medicine. He studied internal medicine at Stanford University and dermatology at Yale. He began his career at the NCI in 1975. In the 1990s, a team led by Drs. Schiller and Lowy began studying the genetic organization of papillomaviruses. They subsequently identified the oncoproteins encoded by the virus E6 and E7. So all of you pre-medical students and medical students can thank him for that piece of trivia that always comes up on your tests. More importantly, they found that the oncoproteins E6 and E7 could trigger the immune system to produce high levels of protective antibodies. The oncoproteins became the basis of 3 FDA-approved HPV vaccines. This discovery has been transformative in the campaign against cervical cancer. In fact, Australia believes it can eliminate cervical cancer in the next 20 years. I'm not sure you can say that about many other cancers, to eliminate them. And I'm sure that it's going to reduce the current mortality of cervical cancer, which stands at over 275,000 women per year. Dr. Lowy is rightfully the recipient of many awards, including the 2011 Albert Sabin Gold Medal Award from the Sabin Vaccine Institute. In 2014, President Obama presented him with the National Medal of Technology and Innovation. And in 2017, he received the Lasker DeBakey Clinical Medical Research Award, which is widely known as the American Nobel Prize. So we're very honored to have you here today at our conference. Everyone, Dr. Lowy.
Well, good morning, everyone. Thanks so much for this lovely introduction. I really am excited to be here. You are the future, and whatever we can do to try to help you is something that we all need to be doing. And I am especially grateful for your interest in and commitment to global health. So this morning, I'm going to talk with you about cervical cancer from the point of view of as a global health disparity. But I'm going to be using data primarily from the United States, but I think the link to the rest of the world will be made clear both in some of my transition slides as well as in the background slides. For my disclosures, I am an inventor of the virus-like particle vaccine, and the NIH has licensed that technology to the 2 companies that make commercial versions of the vaccines. I will discuss potential off-label uses of the vaccines. Fewer vaccine doses is what I will mention, although hopefully I will not tell you it is standard of care. Instead, I will say this is research. And then I've been involved in some other technology development. So the way I think about cervical cancer is it really is a paradox. It's a largely preventable cancer, but it's very common in less developed countries and also continues to have disparities in the United States. It is a cancer that disproportionately affects women from poor countries and poor women. In the United States, as I'll show you, disparities in incidence have been largely overcome, but differences in mortality rates persist. So let's first look at what happens from a global perspective. And to orient you, this is from a recent paper from the group at IARC that looks at various kinds of cancer incidence and mortality. And in blue is shown the incidence of cervical cancer. In red is shown its mortality. And it's in different regions of the world. And the high-income countries are all down here with a low incidence as shown in blue and an even lower mortality rate. Up here, however, you see especially Africa having the highest rates of cervical cancer. And in addition, you'll note that the proportion of red is actually substantially higher here than it is down here. And that's because treatment for cervical cancer is not widely available in Africa. And this shows you on the right that years ago, we were a high incidence country. And if you look here at the annual standardized rate, it's actually very similar to where it is in Africa. But hopefully, it won't take 50 years here to get down to the area where we are. And the real question that I'm going to try to address is, how can we try to change that over the next few years? This shows you on the left the incidence of cervical cancer in the United States. And in blue are shown Black women, and in the green are shown white women. And what you can appreciate is that when you are looking back in the mid-1970s, there's an enormous disparity between the incidence of cervical cancer in Black women and those in white women, basically a two-fold difference. Over time, that difference has been largely narrowed. So over the last recent years, the last 2 or 3 years, the incidence is actually very similar. However, the mortality rates for Black women continue to be higher than for white women, and probably as a combination of when the tumors are detected, they are more advanced, and probably also the issue of health, of access to first-rate treatment may also be different. This slide shows you what is projected to happen over the next 15 years in the developing world versus the high-income countries in terms of cervical cancer mortality rates. Cervical cancer mortality rates over this 15-year period are projected to go up by about 40% in the less developed regions of the world, whereas there's projected to be very little change. And what this means is that about 90% of worldwide cervical cancer deaths occur in the developing world. And cervical cancer accounts for around 10% of female cancer deaths. So when you're talking about HPV-associated cancer on a worldwide basis, you're really talking about cervical cancer. In the United States, it's a much wider spectrum. The incidence of non-cervical cancers attributable to HPV infection is basically similar to that of cervical cancer, but that's not true in the less developed regions of the world. And so the question to me is, how are we going to try to bend that curve? And I think that overall, the answer is we need multiple modalities to do this. First, primary prevention by HPV vaccination. It has high efficacy. It's relatively easy to implement in low and middle income countries, but there's a very long interval before it will reduce cancer. Second, secondary prevention by cervical cancer screening and treatment of screen-detected precancer. This reduces cancer incidence and mortality faster than vaccination, but it's actually relatively difficult to implement high-quality screening in low and middle-income countries, which is one of the reasons why there's very little high-quality screening in most low and middle-income countries. Last but certainly not least, treatment and palliation of screen-detected cancer. This really is an ethical obligation that is a result from screening. But most low and middle income countries have inadequate resources both for treatment and palliation of screen-detected cancer, and so these three areas really are all needed if you're going to try to make an appropriate assault on this cancer. The natural history of HPV infection and cervical cancer is essentially universal, the same in high and low resource settings. And you have vaccination for primary screening, for primary prevention, and screening for secondary prevention. The red line represents the development of invasive cervical cancer. And the screening, you can interfere much faster than with vaccination. Luckily, most women who are infected with HPV, the infection is cleared on its own, so it's a self-limited infection, and the risk of developing cervical cancer goes away. But for those women who have persistent infection with an HPV type that can cause cervical cancer, they're the ones who are at risk of developing precancer and then invasive cancer. A little more than 6 months ago, Dr. Tedros, the Director General of the World Health Organization, said, "We will eliminate cervical cancer, one of the greatest threats to women's health. We have the tools, and now we have the political commitment." I am not a politician. I am not going to comment on whether or not we have the political commitment. However, we have the tools is largely an aspirational sentiment. It is not evidence-based. The problem is that we have the tools in high-income countries, but we don't have the appropriate tools to be able to be widely deployed in low-resource settings. And what I'm going to tell you about are some approaches that I think have the potential to lead to making, at least the part we have the tools, what Dr. Tedros said, making it correct. So, the potential to control cervical cancer in low and middle income countries really will depend on research, and research that leads to changes in standard of care. And there are two principal ways in which this can be done. One is by technological innovation that leads to a new intervention. And the second is by demonstrating that off-label use of an approved intervention is more cost-effective than when used as currently approved. And these approaches can complement implementation research whose main goal is to increase uptake and dissemination of a proven intervention. I'm going to be focusing in this space, but clearly we need, once there is a change in standard of care, we need to do the appropriate implementation research so that the intervention can be widely disseminated. First, an issue about safety of the vaccine, and this is taken from a review from 2016 from the CDC, basically saying safety data have been reassuring with no confirmed safety signals identified. And in Australia, it was reviewed also last year with similar conclusions. These are the results of the phase 3 trials of the 3 different HPV vaccines. The HPV vaccines are actually based on making the virus-like particles, which you see here, made from L1, which is the main structural protein of the virus, and it induces high levels of antibodies which are protective and interfere with infection and disease. If you look here on the right, you can see that the efficacy in women who had no genital HPV infection at the start of the trial was over 95%, whether you're talking about precancer, cervical precancer, or you're talking about genital warts. And so the mechanism for protecting against genital warts is actually very similar to the mechanism in the female mucosa. We're going to talk a little bit about the HPV types, and I just want to point out that Gardasil, which is the quadrivalent vaccine, is targeting the two most important oncogenic HPV types, 16 and 18. It also targets the genital warts. I'm not going to show you genital warts today, and instead we're really going to be focused more on cervical cancer. The Cervarix, which is the bivalent vaccine, just has particles from 16 and 18. And it also has some cross protection with some of the virus types that are in Gardasil 9. And Gardasil 9 has these 5 additional types. These were the first successful vaccines against a locally sexually transmitted infection. And in 2016, the Gardasil 9 was approved for 2 doses for 9 to 14-year-olds. And I'm going to show you some data that relate to Gardasil 4 versus Gardasil 9 in a couple of minutes. This just shows you early on, as you would anticipate for a vaccine that is as protective as the phase 3 trials showed, the young women who got vaccinated, high-grade cervical dysplasia in Australia went down very quickly. And there are lots of subsequent studies, both with Gardasil as well as with the GlaxoSmithKline vaccine, Cervarix, showing analogous dramatic decreases, not just in dysplasia, but also in the prevalence of the HPV types targeted by the vaccines. And in the women who were too old to get vaccinated, no such decline. So Gardasil 9 is the only vaccine that is sold now in the United States, although Gardasil and Cervarix are both FDA approved as well. And what I'd like to show you is that there's actually a big difference between precancer, in situ cervical cancer, depending on racial background. But there's very little difference when you look at invasive cancer. And this is from the largest study from Mona Soraya and her colleagues at the CDC of precancers and invasive cancers in the United States. First, if you look up here, 16 and 18, you can see very similar percentage attributable for cervical cancer. These are the 5 types that are added in Gardasil 9. Again, very little difference racially. But if you look at in situ cervical cancer, which really is precancer, there's an amazing difference. This was not anticipated, but there are now several studies that have shown that a much lower percentage of African American women have precancer attributable to HPV 16 and 18, although their invasive cancer is indistinguishable, if you will, from white women. But if you will, the good news is that the benefit of adding those 5 types is actually bigger for African American women than it is for white women. Although the total percentage predicted to be prevented by Gardasil 9 is somewhat lower for African American women than for Caucasian women, and Hispanic women fall essentially in between. Now, as many of you are aware, there's tended to be underuse of the vaccine in the United States. And these are the data from the data really from 2017 for teenagers. And about 2/3 of eligible teenagers have had at least one dose of the vaccine. Notice substantially lower than the meningococcal vaccine, which is another vaccine that for adolescents that was approved at a similar time to the quadrivalent vaccine. An interesting difference is that a higher percentage of teenagers who are from poor families have been vaccinated compared to the families above poverty. And this probably has multiple explanations, but vaccine hesitancy on the part of providers and issues about the appropriateness of vaccination play some role. But note that there's no difference here when you look at meningococcal vaccines. Statewide, Texas is one of the states that looks at individual counties, and I just thought it'd be interesting to see that in Dallas, the vaccine uptake is really still relatively low, although the meningococcal vaccination is high. In El Paso County, very high uptake of the vaccine, a little bit higher. I have no idea whether the wall in El Paso has made any contribution to this uptake. This slide depicts for you really what I consider to be sort of a mismatch between HPV vaccine uptake in the United States and cervical cancer mortality rates in the United States. In red here are the higher incidence, the higher mortality rates in the United States, whereas the lighter blues represent the less vaccine uptake. So the areas with the highest vaccine uptake are actually the areas that have less cervical cancer. I don't mean that there should be less uptake in those, but it's too bad that there hasn't been the same kind of emphasis on uptake in the areas with high incidence of cervical cancer. And the CDC has, for quite a number of years, been emphasizing the importance of HPV vaccination. I'd like to turn now to cervical cancer screening, and my bad joke that it's not your mother's is really related to the enormous advances that have been made as a result of pap smear screening and follow-up, which really was able to be an advance because it clearly identified cervical precancers, which are much easier to treat than invasive cervical cancer. And as you saw, we went from being a high incidence country to a low incidence country, largely as a result of the pap smear. But there is another revolution going on, which really has to do with understanding the etiology of cervical cancer. And instead of being based on pattern recognition, which is expensive, requires specialized expertise in cytology, and is not readily exportable to the resources in the developing world, HPV screening is etiology-based. It's more sensitive, better at detecting the adeno precursor, and higher positive and negative predictive value, and it's more readily exportable to low resource settings. But the problem is that HPV-based screening is too sensitive. Many HPV infections do not need to be treated because they don't represent precancer, and they're likely to be self-limited. And so what you need in addition to HPV-based testing is so-called ancillary testing to triage HPV-positive women. And there are a variety of triage tests that are under study. I'm going to mention two. When you're thinking about the approaches for screening in low and middle income countries, to me, there are two major approaches. This is actually the one that the vast majority of people in the field prefer at this time, which is see and treat single visit programs. You need to see all women if you're going to do this, but women who are seen can be treated immediately if they have a precancer. And so that's the real advantage. The problem at the moment is there's no scalable, high-quality standard of care approach that is cost-effective enough for widespread implementation in low and middle income countries. A second possible approach would be self-sampling. And the theoretical advantage of this approach is that you would only need to see those women who would need to be treated. So if you needed to treat, let's say, 5% of women, you would only need to see 1 woman in 20 rather than seeing all 20 women with the see and treat program. Problems: not yet standard of care. It requires a central laboratory, and it's not yet clear how you would be able to ensure that the women who need treatment actually receive it. But I personally think that going in both of these directions would be helpful, and self-sampling is an area where I think that it would also be very beneficial in the United States for women who at the moment are underscreened. My colleagues at the NCI are essentially trying to change the algorithms of how we do screening for cervical cancer so that it becomes risk-based, so that down here you have low risk, up here you have high risk, and the way you are managed really is dependent on your risk. And risk really is going to depend on probably 3 parameters. The first is your age. The second is whether you're HPV positive and what HPV type it is, because HPV 16 is more oncogenic, say, than HPV 52. And then what the result is for an ancillary test. So one of the tests that's being looked at is viral methylation. It turns out that when women develop high-grade dysplasia, a fair number of the potential methylation sites in the viral DNA become methylated, whereas early in infection, before you get precancer, they are not methylated. And this is associated with silencing of those areas. So there's preferential non-methylation of the regulatory region as well as the region that expresses the 2 major oncogenes, E6 and E7, but there's methylation of other areas. And so this is a paper that was published about a year ago from colleagues at the NCI, particularly Mark Schiffman and Nico Van Benson. And this shows you, if this is the threshold for referral for colposcopy, they've been able to essentially develop the test so that it is sensitive enough that if you are negative for methylation, you don't need to be referred to a colposcopy. But with some exception, if you're positive, you should be referred to colposcopy. This is also being evaluated for self-collected specimens and using basically a linked robotic assay so that in one test you could find out a woman is HPV positive, what her genotype is, and also do the methylation if she is positive, so that this could be done either as a result of an office visit or with self-sampling. This is research, not FDA approved. The idea here is to try also to reduce complexity for providers, where you would essentially be integrating what the risk algorithm was, and the provider would essentially get a recommendation of how the patient should be managed. And you could easily imagine that with the use of a smartphone and the input of these kinds of data, you could tailor the recommended management according to the resource setting where you were. Again, research not yet FDA approved. The second approach that I want to discuss is visualization with acetic acid called VIA. My creative use of, that's a spelling error, not intended to be just VIA visualization. And basically, it's visualization of the cervix with acetic acid, which colors it so-called aceto-white. It has been touted as a low-cost approach for detecting precancer. But what it really does is simply to downstage invasive cervical cancer. But as we've noted, treatment is generally not available for invasive cancer in most low and middle income countries. And a very nice study by Shastri and his colleagues from Mumbai with basically local workers doing VIA, and it decreased mortality rates, but it was only after a few screens. And also, instead of being for precancer, it downstaged invasive cancer, having the Tata Memorial Hospital next door where the women were treated really played a very important role in the reduction in mortality rate. But it turns out that machine learning from digitized images, which is now being referred to as automated cervical evaluation, or AVE, can greatly increase the sensitivity of this approach to actually detect cervical precancer. In this paper from Mark Schiffman and his colleagues at NCI, as a collaboration with investigators at the National Library of Medicine, but also a Bill Gates-supported group called Global Good, basically were able to do machine learning, artificial intelligence. And at the NCI, this is actually being supported as a cancer moonshot initiative. And I'll just show you two pieces of data from the AVE algorithm. This basically looks at the receiver operator curve, and basically it looks as though just this approach, you could detect about 90% of cervical precancer. And if you used HPV detection and then use the automated visual evaluation, this would be a similar detection. My personal view is that when more field studies are done, this may turn out to be overly optimistic. And my own feeling is that coupling this to HPV detection will end up being the way to go. Again, this is research. The expectation is that over the next 3 years, there will be sufficient clinical trials done in the field to lead to provide evidence, so that if the evidence is strong, there will be FDA approval and also recommendations from the World Health Organization. The last topic is whether a single HPV vaccine dose might confer years of protection. Now, why is this important? And the reason that this is important is really shown here. 5% of eligible girls in low and middle income countries have been vaccinated. And so this is really, and this is where the need is. You know, if you, the yellow and red, you notice it really, almost all of it is in the high income countries. That's where the majority of vaccination has been given. These are the eligible girls, and the vast majority of them are in low resource areas. Very few of them have been vaccinated. And just to keep in mind, there are 60 million girls born each year worldwide. So on the one hand, having vaccinated more than 100 million girls is, if you will, a good achievement. Just think about where you might want to be if there was going to be global deployment of the vaccine. So my own feeling is that 2 doses are not only more expensive, but also logistically much more complicated. And so there's post-hoc evidence for protection from a single vaccine dose. And the NCI has conducted a vaccine trial in Costa Rica, which have been published. Data from 7 years have been published. I'll show you some unpublished data from 11 years out from that trial. And the International Agency for Research on Cancer India trial have published analogous data with shorter follow-up in Lancet Oncology and Vaccine. Once again, insufficient evidence to change standard of care, but sufficient evidence to warrant rigorous evaluation of single-dose potential. So this looks at the prevalence of HPV infection 11 years after the bivalent vaccine. This is the GlaxoSmithKline vaccine, Cervix, that was used in the Costa Rica vaccine trial. Take-home message: 1 dose is not inferior to 3 doses. Let's first look at the protection from HPV against HPV 16 and 18. Then in red is cross protection with these 3 HPV types that are shown in other settings also to have cross protection with Cervix. So if you just look at the height here in the control group, the height for these 2 much higher than here, and basically indistinguishable. This is the prevalence 11 years after vaccination, whether you've had 3 doses, 2 doses, or 1 dose. In terms of balance, there are many HPV types that are not protected by the vaccine, and their prevalence is very similar among those 4 different groups, suggesting similar exposure in terms of HPV. Even more remarkable is that the serum antibodies to 16 and also 18, 11 years after 1 dose, have remained remarkably stable. Basically 100% of the women who only got 1 dose still have good antibody levels. And note that they're substantially higher than the antibody levels of the women who have natural infection with HPV 16. So we think that this is good enough data to have a randomized controlled trial, again in Costa Rica, to test the efficacy of 1 dose versus 2 doses. It's supported partially by the Gates Foundation and by the NCI. And it's going to be testing 1 dose versus 2 doses of the GSK vaccine and 1 dose versus 2 doses of Gardasil 9. Because of its non-inferiority design, you can't do a placebo-controlled trial because these are approved vaccines. You need a lot of women in each arm. So there's about 5,000 women, 12 to 16, in each of these arms. And then to get at what the efficacy, there's going to be a survey of prevalence in the region. It's a 4-year primary trial with longer-term follow-up. And if you want more information, it's registered at clinicaltrials.gov. And Amy Kramer, who is the principal investigator at NCI, wrote a perspective article last year. This trial started about a year ago. Patients are accruing, but it will be several years before we know what will happen. If 1 dose demonstrates strong protection, it could change standard of care in the United States and globally. In the United States, it could save more than $300 million each year in vaccine costs, but particularly it could make it feasible to control worldwide public health problem of cervical cancer and other HPV-associated cancer. This slide is speculation, okay? This is where I think we might be by 2025. We would have vaccination to prevent HPV-associated cancer, and evidence-based single HPV vaccine dose will be recommended by the World Health Organization for young adolescents. Cervical cancer screening. Several high-quality, cost-effective approaches will be FDA approved and recommended by the World Health Organization, including the option of self-sampling for women. So what are the take-home messages? Basic research led to identification of HPV as the cause of several cancers and to development of the HPV vaccine and etiology-based cervical cancer screening. HPV vaccination has the potential to reduce all forms of cancer attributable to HPV infection caused by the types targeted by the vaccines. Current research may lead to changes in standard of care that would make it feasible to control the worldwide public health problem of cervical cancer and other HPV-associated cancer. Thank you all for the invitation. I look forward to your comments and questions.
So we'll take questions at this point. Does anyone have questions?
So Doug, some of the discussion we had yesterday was ethics of clinical trials. The ethics of doing clinical trials in low-resource settings, and we have the same issue in the U.S. when you try to back off a standard of care, which is 2 or 3 going down to 1. And I'm sure there were discussions about how you could design that trial. And I think that would be interesting to have your perspective of how that was considered.
Well, I think the first issue was we didn't think that having a placebo-controlled trial was ethical, even in a country such as Costa Rica, where the vaccines are approved, but they're not part of the national program. The second is that one of the advantages of vaccinating young women between the ages of 12 and 16 is that if it turns out that one dose is not quite as good as 2 doses, we can always give the women who got just 1 dose the option of taking the second dose. Those are basically the way we have thought about that, and that's part of the protocol.
Yes, thank you so much for your presentation. It's very interesting. I had a couple of questions that relate to HPV, particularly when you mentioned the context of HPV-associated cancers and neoplasias. One is that you're specifically saying that the HPV vaccine will be recommended for women, and there's a question about what should we be doing for boys, leading to the issue of how, if you could elaborate about some of the other HPV-associated cancers and what the evidence shows. And also I was wondering if you had any comments about some of the reticence that persists around HPV vaccination and acceptance of HPV, whether it's gender-based, women only, or available and accessible or recommended, if you will, for both girls and boys. Thank you so much.
Sure. Let's see, in the next hour, I'd like to, so first, in terms of reticence, I think that the rate of uptake of the vaccine, started, of course, with more young women being vaccinated than boys, because first the vaccine was initially only approved for women. And the strong recommendation for males only started in 2011 for the cancer prevention. And since then, the increase in the percentage of boys who are vaccinated actually has gone up faster than the percentage of girls. So I would say that there probably is greater resistance among the parents of girls than among the parents of boys. The CDC published on this a few years ago. I think that the parents of girls who didn't get the vaccine, a major reason was concerns about safety. Whereas for boys, It was primarily they didn't know the vaccine was recommended. So real qualitative differences. In terms of gender-neutral vaccination, the models indicate that if you have high uptake of one gender, at steady state level, you don't need to vaccinate the other gender. On the other hand, if you're in a situation with low uptake and just vaccinating one gender, there is real utility to vaccinating the second, the other gender. And so that's basically what led to the immunization, the Advisory Committee on Immunization Practices to strongly recommend the vaccine for boys, because we were in this area where there was sort of under vaccination. In addition, because the boys wouldn't be getting the benefit of herd immunity because of low vaccination of girls, you were placing them unnecessarily at risk for developing their infections. Right now, we have a shortage of HPV vaccination. I'm sorry, of HPV vaccines. A worldwide shortage. Demand exceeds the supply. It's likely to stay that way for at least another 5 years. After that, it seems to me, if people want to do gender-neutral vaccination, that's just fine. Another purpose for gender-neutral vaccination is that the modeling suggests that gay men are not going to be protected if you just vaccinate women, whereas if you vaccinate both genders, then over time you will eliminate HPV in men who have sex with men. I guess the last question was the vaccine seems to be as protective against HPV infection in the mouth as well as in the anogenital tract, but it is not FDA approved for prevention of oropharynx cancer, largely because there is not a clinical lesion with oropharynx cancer, in contrast to anogenital.
Could you speculate, as you know more about the durability of the immunity, the feasibility of giving this at school entry rather than to 12 and 16-year-olds?
Yeah, I mean, this is a question that people ask about, and my guess is that in another few years it will be fine to do it. The problem is that you're making more of an investment up front before you see the benefit. In addition, the CDC would prefer to have an adolescent platform for vaccines. They feel that young children are already getting a lot of vaccinations already.
But as you know, there's a stigma associated with sexually transmitted disease and puberty that has led, especially in a country like India,
sure,
to a lot of resistance.
Sure. I mean, I think that I think that it will, once there's been, a few more years of protection, and if it's clearer that you don't need a booster, then I think it will make it easier to go down in age if that was something that a country wanted to do. Yeah.
Hi. Thank you for your talk. My question was in regards to the recent FDA expansion of the age group, whether you felt that vaccinating up to 45 years old was something that was worthwhile doing, and especially in someone who maybe has high-risk sexual practices.
Sure. Well, I think that the data about risk of cervical cancer suggests that most infections that lead to cervical cancer occur in women before they're 30. And so the utility of vaccinating women over the age of 30 in terms of preventing cervical cancer is probably marginal. But if a man or a woman has had relatively little sexual exposure in terms of partners, et cetera, and that behavior might be in the process of changing, that setting might make good sense. I also think that one should at least raise the question during this period of a worldwide shortage of the vaccine. What's the ethics of saying that we should be vaccinating many more people at these older ages, where the cost-benefit analysis is substantially lower than the cost-benefit analysis, say, of vaccinating younger people? I'm not trying to give you an opinion. I just think it's worth raising that question.
Thank you.
Thank you for your talk. Just need to know if you can shed any light on what efforts or what push is being made to include HPV vaccine in the immunization schedules for children in low and middle income countries.
Well, there's a continual expansion of more and more countries that are implementing HPV vaccination in their national programs. Most countries, with some notable exceptions, the deployment has been relatively modest. But there have been some really notable exceptions. For example, Rwanda, very high uptake of vaccine among young girls.
Thank you.
Dr. Lowy, it's been a privilege to have you speak at our ICEC Young Investigators Conference this morning. Thank you for reminding us of the power of scientific innovation that doesn't lose sight of the patient. On behalf of our planning committee, we just would like to give you a small token of our appreciation for your support and for being here today. So thank you very much.
Thanks so much.
Thank you. Just everybody will have a short break now, and then we'll regroup at 9:50 to continue the programming. Thank you.